Okay, so I know there was kind of a general audience, so I tried to put together a general overview with some example of the work that we have done and what we are thinking to do as a next step. And so I wanted to start with a background. And so the effect of air pollution on health has been born, let's say, with three major disasters in Belgium, in Pennsylvania, and in London. And in all these three disasters, very high level of pollution were associated with higher mortality. And since then, many studies have looked and examined these associations. But I would say the PM2.5 or particulate pollution in general still remain an overwhelming problem. And you can see here some, some pictures, and this is in China not many years ago. So air pollution has actually been rated among the 10 top risk factors by the attributable burden of disease in 2010. And as number 3, we have household air pollution from solid fuel, and as number 9, ambient particulate matter pollution. From here, we can see that really pollution is still a public health concern. And so ambient particulate matter accounted for around 3.2 million excess deaths with a 3.1% of disability adjusted life, and household air pollution with 3.5 million excess deaths. And so this is actually a map of the world, and what is plotted here color-coded are the ratio of PM2.5 between 2005 and 1990. And so what you can see is the red parts are where pollution have been increasing during the years. And so while we can see that in the US, the PM2.5 is not increasing too much, but you can see like in Asia and Africa, the level of pollution is still increasing. And it has been estimated that between 1998 and 2012, PM2.5 concentration have been increased for around 2% per year. So what we want is reduce particulate pollution. And since several years, the National Research Council stated that among the major important research priority are to set the standard for the criteria pollutants and really to understand which is the relationship between air pollution and health. And under the Clean Air Act, the EPA set the national quality standards for the criteria pollutant. And you can see here the list of the pollutants are ozone, lead, sulfur dioxide, NO2, and PM. And these are periodically revised. And so now I wanted to give you actually, I don't know how many of you know, I mean, I think many of you know about PM2.5 here, but I just want to tell you what is a particulate matter. And so this is a complex mixture of extremely small particle or droplets found in the air. And it can be divided between primary particles and secondary particles. The primary particles are the ones that are directly emitted from a source, while the secondary particles are created after a complicated reaction in the air. And these are the ones that make up most of the fine particle pollution. And how big is PM2.5 or particle pollution? So here there are two figures, and the one that I like the most is the one, is this one, where you can see this is a hair. And so a hair can have a diameter of about 50 to 70 micrometers. And what you can see with in blue, this is the PM2.5. So, sorry, PM10. So PM10 has a diameter less than 10 micrometers. And PM2.5 is this one, it is even smaller. So has a diameter of less than 2.5 micrometers. And so practically a PM2.5 is 30 times smaller than a human hair. And how does pollution affect our health is we breathe. We breathe and the pollution enter the body and through the nose and the mouth, and so goes down. Some of the larger particles are eliminated, but the rest penetrate into the lung, the alveoli, and creates really heart disease and lung disease, among others, I would say. So in environmental epidemiology, our goal is really to identify and quantify the influence of particulate matter on health. And to do this, there are several steps that are very important. And so one is really to quantify the relationship. And to quantify, we need to develop mathematical and statistical models. We also need to identify which subpopulation are the most susceptible to the effect of air pollution. And we also, one part of it is very important, is we need to understand and to study which are the psychological mechanisms leading that mediates the air pollution and the effects of air pollution on health. And finally, another important part is also to develop models to improve exposure assessment. So I'm going to give some examples. So there is a lot of existing literature up to now. And so many studies actually around the world, not only in the US, have found significant association between particulate matter and health outcomes. And usually exposure has been examined or as short term. That means you look at the exposure, the level of PM today or yesterday, or the average of these few days. Or we can look at long-term exposure. That means annual average. So you can do a 365 days moving average for or 1 year or 2 years or more. And obviously, both these two, when you study acute health effects or chronic health effects, there are different types of modeling that have been applied. So I'm going to give a couple of examples of study of short-term PM 2.5 exposure. And so in the first one, so this was one of the first studies where we, to look at the effect of PM 2.5 on mortality. Up to that time, PM 10 was the particulate matter more available and that we could study more. And so what we wanted to do is to really test the hypothesis that PM 2.5, but also PM cores were associated with mortality, where PM cores is computed as the difference between PM10 and PM 2.5. And another example that I'm going to show you instead is moving from the mortality, cardiovascular mortality, respiratory mortality, or hospitalization to an interest in neurovascular dysfunction and neurodegeneration. And so what we did is to examine if PM 2.5 increases the risk of hospitalization for neurological disorder, and then we added diabetes because subjects with diabetes are a very susceptible population. And so this is the first one. And we did a multi-city study. The map include all the 112 cities that we examined. And so the symbol of the symbol size represents the population, so how big is the city, and the color, the PM 2.5 average in that city. And so you can see in red, we have higher PM 2.5 here and here in California, and the level are a little bit lower in other parts of the country. To do this study, we use mortality data for the years 1999 to 2005, and we look not only at total mortality, but also cause-specific mortality. And you can see here specifically we examine cardiovascular, myocardial infarction, stroke, and respiratory disease. And for pollution, we use the PM 2.5 and PM cores from the ambient monitor from the EPA AQS. So these are the results of this study. Hoping it's not too messy. So first of all, we found a significant effect of PM 2.5 of mortality. It is the first one here overall, and it's around a 1% increase in mortality for 10 microgram cubic meter increase in PM 2.5. The sum of the distributed lag means that it's a cumulative effect over 4 days, and so we also find this significant effect cumulative effect. And then we did an analysis by season. And so we found the spring at the higher effect of PM2.5. And one reason could be that in spring is when you keep your window open much more. Like in winter, they're closed. In summer, they're closed because of more use of air condition. But the spring is when really the windows are more open, and so you breathe more. There is more pollution inside the houses. And so then you can see here are the results for the specific causes. And so there are still significant effects, and actually for like stroke, respiratory, from here, and MI, the effects are even higher compared to the effect of total mortality, of PM2.5 on total mortality. And then these are the results when we compare PM2.5 and PM cores. So the analysis was restricted to only 47 cities where PM10 and therefore PM cores was available. And these are the results for from a two-pollutant model. So in the same model, we adjusted for both PM2.5 and PM cores. And so you can see that there is still significant effect of PM2.5 across all the different cause-specific mortality. But we also found a significant effect of PM cores. This is the second example, and here we looked at hospitalization. So first of all, the map again represents the cities, and we examined 121 cities this time. We use Medicare data. So Medicare is provide hospitalization for individuals 65 and older. And so we had cause-specific hospitalization, and we selected dementia, Alzheimer's disease, Parkinson's, multiple sclerosis, diabetes. Moreover, Medicare provided date of death. So we could also extract mortality within the Medicare population. And so, oops, sorry. And so what we examined was, first of all, the effect on mortality in Medicare data, but then we also look if the mortality effect was modified by having a previous hospitalization for a neurological disorder. And then we focused just on hospitalization, and so the effect of PM2.5 on these specific causes. And so these are the results. So we found a 0.64% increase in mortality among the Medicare enrollees in 121 cities. And then when we look at effect modification of the mortality risk by previous cause of hospitalization, we found this significant effect, but these are not significantly different than the mortality estimate. Very interesting instead was when we focused on the cause-specific hospitalization, we found that a 3% increase in hospitalization for Parkinson's disease due to PM2.5. We also find a 1.14% increase in subjects with diabetes. I wanted to show you now a couple of examples of long-term exposure to PM2.5. And again, given this interest in neurological disorder, we thought to see, and these disorders are maybe not just acute, but maybe chronic, so we thought to look at the long-term effect of PM2.5. And so we examined the long-term PM2.5 exposure on first admission for one of those hospitalizations. And in the second example instead is looking instead at which other modifier are important in the mortality, in the long-term mortality PM2.5 association. And so for the first study, we focus on these 50 cities. And again, we use Medicare data. We had around 9.8 million subjects, and you can see there were 266,000 Alzheimer's admissions and around 120,000 Parkinson's admissions. And these are our results. So we found that per 1 microgram cubic meter increase in annual PM2.5, we found an hazard ratio of 1.15. This is like, say, a 15% increase of hospitalization for Alzheimer's disease and an 8% increase in hospitalization for Parkinson's disease. And so this was actually one of the first studies to examine the long-term effect of this specific hospitalization for neurological disorder and annual PM2.5. And because this was the first, I think more studies are needed to prove and to see if this association is causal, and because it's very important for public health. In the second study, we examined 207 cities. So this was even bigger study, and using Medicare data, again, and the PM2.5 from the EPA monitors. And then we examined all of these city-level characteristics. So we did an analysis in each city to look at the effect of annual PM2.5 on mortality, and then we'll look which one of all these characteristics modify the association. And so these are the results. So we found a 19% increase in mortality per 10 microgram cubic meter increase in annual PM2.5. And then when we look, this one that I present here is the one that were the more important or significant association, and the results are presented. So the effect of PM2.5 at the 25th percentile and the 75th percentile of the distribution of our city-specific characteristic. And practically what we found is that living in cities with a low socioeconomic status is associated with a higher effect of PM2.5 on mortality. So there are many studies, and I think they're all very important, but obviously there are some issues, and we need to move on to see which are the issues and how we can better improve our health. And so among the issue is that, monitoring data has been really very useful, and but, they estimate an average of the population. And with this monitor, with this monitoring data, we cannot assess if there is a difference between rural areas and urban areas. And moreover, we cannot capture exactly the spatial variability of PM2.5 concentration, and therefore there is some measurement error. We cannot even, so usually the study have been looking at short-term or long-term independently, but it would be nice to see the two together in the same model, which is more important. And moreover, I think, the EPA is reviewing the standard, and right now, if we want to lower more the standard, we have to show that there is an effect at even lower concentrations. And so in order to moving forward, we need to improve exposure assessment and to do more studies of the health effects of air pollution at even lower level of concentration. And so in order to improve exposure assessment, so I showed you all my analysis included monitoring station, which are very nice and represent the average exposure, and but could be computed only for a county. And were very good express the temporal variation, but we want to have a little bit more spatial variation. And so land use regression models were able to give more spatial variation and estimate PM2.5 using these land use regression variables. But these models usually can only estimate annual level of pollution. And so in order to have both temporal variation and spatial variation in PM2.5, we developed this spatially temporal result prediction model. So these are very complicated models and are very novel. I think the first paper we published was in 2011. And so to do this, to predict PM2.5, we use both monitoring PM2.5, land use regression variables, meteorological variables, but also satellite-based remote sensing data on aerosol optical depth. That means we get the data from the satellite that goes around Earth. So there is first a big work to get this data and to clean it, and then to be able to use it for our models. But with these models, we are able to estimate PM2.5 at the 1 by 1. Originally, the first models were at the 10 by 10, and now at the 1 by 1 kilometer grid on a daily level. So in this way, we are able to capture both the temporal and the spatial variability. And so this last example has been just published, this paper, and we try to put all of this together. And so we used the PM2.5 estimated at the 1 by 1 kilometer grid using the satellite data. We estimate in the same model both short-term and long-term PM2.5, and we also focus on the effect of low concentration of PM2.5. So this is a map of New England, and color-coded is the mean PM2.5 concentration estimated at the 1 by 1 kilometer grid for 2004. And so you can see that it's really very nice, and here is Boston, and you can see this higher, this red color, so higher PM2.5 that goes down towards New York, while here is in Maine, there is a lot of green, and so there is less pollution. Again, we use our Medicare data from 2003 to 2008. So Medicare individual data is available at the zip code level. And so instead of using aggregated at the county level as in the previous study, because we have PM2.5 at the grid level, we were able to do the analysis at the zip code. So we average the 1 by 1 kilometer grid over the zip code. And so we kind of have less measurement error. Our exposure, we define the short-term exposure as the 2 days average of PM2.5, and the long-term exposure as the yearly average of PM2.5. And moreover, we always also restricted the analysis to annual concentration below 10 microgram and the daily below 30 microgram cubic meter. And so these are the results. So you see the short term and the long term, and this is in the full cohort. And so we have a 2% increase in mortality for 10 microgram cubic meter increase in PM2.5. This estimate is similar when we examine for low concentration of PM2.5. But when we look at chronic long-term PM2.5 exposure, we found that in the full cohort, a 7% increase in total mortality, which increased to around 9% when we restrict to concentration of PM2.5 low, less than 10 micrograms. And so these are very important results because, for the first time, we have this mutually adjusted model, and we show a significant effect of both short and long-term exposure when adjusting one for another. And we also show that the effects are still very high also at low concentration. And we also did the dose response curve. So this is really the smoothing function. So the curve represented the relationship between PM2.5 here and mortality here. And this for the daily and for the long term. And so the adverse health effects occur also at low level of fine particles. And so even if we improve even more the air quality below the national air quality standards, this can still yield health benefits. So in conclusion, based on the literature, there is a causal effect of short-term exposure to PM 2.5 and mortality. And there is also a strong evidence for other outcomes and for chronic exposure. Moving forward, I think that we need more study to really examine the health effects at low concentration so that we can help the EPA lower even more the PM 2.5 level. And so more study I think are important and required to estimate both acute and chronic effect, to estimate the effect in rural area and low concentration, and also focus on many more, not only city-specific characteristics, but in this way we can also see which other characteristics of the city are important and to lower this concentration. Finally, I would like to acknowledge and thank the funding agencies that allow us to do this job, and my colleagues at Harvard. Thank you.
And Antonella has agreed to take some questions here now from the audience. Right here.
I guess could you comment a little bit on the issue of possible confounding, or whether there are factors not included in your analysis that might affect your findings?
Yeah, I mean, there is confound. You know,
other pollutants and maybe other.
Yeah. So the type of models that we've been using, you know, time series, case crossover, survival analysis has been used in many studies, and they have been improved, and we try to adjust to all possible confounders, but obviously there are possible others. And when you talk about other pollutants, it's a very important point. It's very difficult to do multiple pollutant models because the pollutants can be correlated, and you know, it's very hard to see which one is more important. And so there is some work that has been done for that, and there is, you know, but you know, more needs to be done. Yeah. Yes?
Oh, wait.
I was wondering, you showed some increases like in Parkinson's and Alzheimer's and so on. Are there other people looking at what the mechanism could be linking the particulate to those particular diseases? Like
So I think part of the idea is that when you breathe in the air, and so usually we say we have, you know, goes in the lungs, and so it's mostly cardiovascular, affects the heart and the lungs, but it actually goes up to the brain. And so there is cerebrovascular impairment that can cause that. And actually, I don't remember exactly, but both the Parkinson and Alzheimer has been linked to air pollution in previous studies.
First of all, wonderful talk. Thank you very much.
Thank you.
You articulated that there's an enhanced PM 2.5 mortality rate during spring. And you indicated that that's perhaps due to opening of windows. I see a bit of a paradox here, because fresh air itself has some benefits, but two, how do you know that people were indeed opening the windows, or that's just a speculation on your part?
Yeah. So one point is that you have to think that lots of people stay indoors. Right? And so you don't breathe all the pollution that is outside. You breathe the one that is outside when you are outside or going in the traffic or like this. And so in general, you can think that, you know, in the winter you don't open the windows, and in summer you don't open the windows. And so, or maybe it's just not open the windows, but just being outside more. And so, you know, so that could be another idea. So yes, I kind of speculate, but, you know, that's the reason it came in my mind, that people stay outdoor or open the windows more. And so therefore you breathe more the ambient pollution.
Senior citizen studies. One thing about senior citizens, they're consistently the largest growing voting population. And in North Carolina, that's extremely important. But with the Harvard system, are you letting senior citizens know that this happens? I mean, Harvard's got newsletters, they've got media access, and, this is extremely
Yeah.
important.
The funny thing is, PM 2.5, I think also in a cell phone now there are some apps that tells you how high is the pollution level. I've never really do too much of this public health work myself. I guess there is some, but not as funny because there is not as much as what is done for climate change. So for temperature, immediately you know that it's going to be hot and people need to stay indoor. For pollution is not as much. There is for ozone, maybe, for ozone in the radio things, but I think that more work needs to be done for that, yes. Yes.
Same, follow-up.
Just shifting to the diabetes, the excellent data you have on type 2 diabetes. Are you aware of any studies done in type 1 diabetes? I'm only aware of one from Germany showing PM 2.5 having an effect.
I know type 1 diabetes has not been studied as much as type 2 diabetes. Yeah. It would be interesting to do more work on that too. Yeah.
Over here.
So if you were presenting to the general population who was very concerned about the potential health effects, you've been implying that the solution is to stay indoors. Are there other options?
Lower the PM 2.5 levels.
From a policy perspective, but I mean from an everyday perspective, we're trying to encourage people to go outside, to be
Yeah,
more active,
I know.
and you're suggesting that.
Well, there is also the issue that, as I show, who's more affected are people who are more frail. So if you had MI, you are more susceptible than a healthy person. So if you're healthy, the effect of air pollution are not as strong on you as if you have diabetes or if you have a cardiovascular disease. So, no, I don't want to stay indoor. No, go outside and walk is very important, but we need to find, some solution. You're right.
I really enjoyed that talk. Really did a great job, and I really enjoyed the satellite analysis because that again overcomes some of the deficiencies in monitoring stations that exist. In looking at North Carolina pollution, we try to look at satellite analysis, and sometimes the satellites don't go over the entire state. They'll just take a couple cuts through North Carolina. In your New England experience, did you have complete coverage, or were you able to?
No. That's why we cannot use only satellite data. For example, if there are clouds, you don't get the measurement. So that's for the temporal variation, so on a daily level, and then there are some area that are less, and so that's why we also need to use the monitoring data, all the possible available, as well as weather and other characteristics to be able to fill in the missing. So the process to estimate those prediction for PM 2.5 is very difficult and very long, and it includes several stages. And so that's how we were able to get a final estimate.
Yes, over here.
Can you comment on the averaging, the 2-day average for PM 2.5? I've never heard of a 2-day average.
So we use a lot in environmental happy the average of pollution, because sometimes when we have been looking at single days, so we can look at today's effect, yesterday effect, 2 days ago effect, and so it can vary. Sometimes it's just the same days, and sometimes there is a little bit effect on the second day, and so by using the average, it's kind of the effect of today and yesterday together. So it's an average of Using only 1 day can be kind of restricting, but it can be a little bit more cumulative, the effect. And so using an average of 1 or 2 or 3 days can also provide this effect that is prolonged for some days.
I'm just curious, because the standard would be a daily standard.
Yeah, yeah. Yeah, so we also have been looking at single pollutants, but very often we also look at average or distributed like models where you examine several days in the same model to see which one is more important.
You had mentioned at the very beginning when you showed your map of the country, you said that pollution has been increasing in Africa.
Well, it seems that in some spots were more red, and so you can see, and there were like in some North African states, it seemed a little bit higher, and like in Asia, mostly in Asia also seemed being more increasing.
And was that a certain year, or what was your?
I don't remember exactly for that map. I think it was for 2010. It's in the publication if you're interested.
Thank you.
Thank you.